All right. Hello once again, everyone. My name is Dr. Julian Yazid, and today I'm going to be presenting on scalp and surface markings. All right. To kick off, we're going to discuss today's objectives for the discussion. In first place is to give a brief anatomy overview of the scalp and the calvaria, as well as to discuss the major midline and lateral craniometric points, to discuss the anatomical relations of each scalp landmark and their surgical relevance, and to outline the various surgical approaches that utilize these landmarks and their principles. All right, so just to give a quick overview, the scalp is composed of five distinct layers, remembered by the mnemonic scalp. The first layer is the skin, which is a thick hair-bearing and continuous and contains numerous sebaceous glands and firmly adherent to the underlying connective tissue. Beneath this lies the dense connective tissue layer, which contains the rich vascular and nerve supply of the scalp. The vessels are tethered within fibrous septae, so when they're cut, they're unable to retract. Right? This explains why scalp lacerations have a tendency to bleed profusely. The third layer is the Galea aponeurotica. It's a tough fibrous sheet connecting the frontalis muscle anteriorly to the occipitalis posteriorly. Right? This layer is responsible for the characteristic gaping of scalp wounds when it's divided due to the opposing pull of these muscles. And deep to that is the loose areolar tissue, often referred to as the danger area of the scalp. And it's a potential space that allows the movement of the scalp over the skull. Important to remember is that it contains emissary veins that communicate with the intracranial dural venous sinuses, providing a pathway for infection to spread intracranially. Right, and the deepest layer of it all is the pericranium, which is the periosteum of the skull. It's loosely attached to the underlying bone, except at the sutures, and this layer is clinically relevant in conditions, where bleeding beneath can be confined by the suture lines. Right. Let's kick off. The scalp cap or calvaria forms the dome of the skull and primarily consists of the frontal bone anteriorly, the paired parietal bones laterally, and the occipital bones posteriorly. These bones are joined by key sutures like the coronal suture between the frontal and parietal bones, the sagittal sutures between the two parietal bones, and the lambdoid suture between the parietal bones and the occipital bones. The intersection of these points of the sutures form important craniometric landmarks such as the bregma and lambda, which are essential for neurosurgical orientation. Structurally speaking, the calvaria bone is composed of two compact layers, the outer table with a central cancellous layer known as the diploid. The diploid contains diploid veins, which communicate the dural venous sinuses and can act as a route for infection spread, as we would have mentioned just previous. From a surgical perspective, the outer table is thick and resilient, and the inner table is, thin and more brittle, making it prone to fracture and inward displacement of the during trauma. So, with regards to the craniometric points, there are, in short, reproducible osseous landmarks that allow, us to translate surface anatomy into a three-dimensional understanding of the intracranial structures. Right, these include the cerebral cortex, ventricular systems, and dural venous sinuses. They form the basis of a mental neuronavigation system and particularly are valuable in emergency or resource-limited settings when surgery is indicated. Right? Starting off with the midline craniometric axis, we have the nasion, which serves as the anterior midline reference point located at the frontonasal junction. And it's used as a starting point for cranial measurements, including the projection of the superior sagittal sinus and the calculation of Coker's point for ventricular access. Posterior to this lies the bregma, the intersection of the coronal and sagittal sutures. Surgically, this point overlies the anterior superior sagittal sinus and approximates the junction between the frontal lobe and the paracentral lobule. It's therefore critical when planning midline craniotomies and interhemispheric approaches where inadvertent sinus injury must be avoided. Further posteriorly, the lambda, formed by the intersection of the sagittal and lambdoid sutures, corresponds to the posterior extent of the superior sagittal sinus and helps to delineate the parieto-occipital region. It's particularly useful in orienting occipital and posterior parietal craniotomies. At the posterior midline, the inion, or the external occipital protuberance, represents a key landmark corresponding internally to the turcular hierophili and the confluence of the superior sagittal sinus, straight, and the transverse sinuses. This makes it indispensable in posterior fossa surgery, where accurate localization of venous sinuses is essential to avoiding catastrophic bleeds. Together, the Nacian and Inian line defines the cranial midline and approximates the course of the superior sagittal sinus, forming the backbone of majority of scalp markings, right? That's it for the midline craniometric landmarks. Onwards to the lateral craniometric landmarks, we have the pterion, which is one of the most important surgical landmarks, representing the junction of the frontal, parietal, temporal, and the greater wing of the sphenoid bones. Deep to this lies the anterior division of the middle meningeal artery, making it the classical site of epidural hematomas following trauma, right? From a surgical standpoint, it's the key entry point for the pterional craniotomies, providing access to the Sylvian fissure, middle cerebral artery, cerebral artery, correct, bifurcation, and the anterior circulation aneurysms, as well as skull-base lesions. Posterior inferiorly, the asterion marks the junction of the parietal, occipital, and temporal bones and corresponds closely to the transverse sigmoid sinus junction. Although slight anatomical variations do exist, and we must keep note of that, it is therefore used as more of a guide in retrosigmoid craniotomy. In this sense, precise localization is required to avoid venous sinus injury while accessing the cerebellopontine angle. The Stephanion, located at the intersection of the coronal suture and the superior temporal line, overlies the inferior frontal region. It's particularly useful in planning frontal bone flaps and helping to avoid inadvertent entry into the frontal sinus, which lies just anterior and inferior to this point. The porion, defined as the upper margin of the external auditory meatus, forms part of Reed's baseline or orbitomeatal line. I'll go into that later down in the presentation. This line is important in both radiological orientation as well as in estimating the position of the temporal lobe and the Sylvian fissure. The zygion, the most lateral point of the zygomatic arch, is less critically surgically, but provides orientation for facial width and lateral cranial measurements. And it can also assist in approximating the inferior extent of temporal exposures. Just to touch up on the posterior inferior and skull-base landmarks, we have the mastoid process, which is a critical landmark in skull-base surgery. It overlies the sigmoid sinus and is closely related to the facial nerve as it exits the stylomastoid foramen. It's therefore central in retrosigmoid and translabyrinthine approaches, as well as in avoiding neurovascular injury. The asterion-inian line approximates the course of the transverse sinus, while the asterion mastoid trajectory reflects the course of the sigmoid sinus. These relationships are fundamental when placing burr holes, for example, in the posterior fossa, where even slight misplacement can result in some very major venous bleeding. In terms of just a functional correlation with the cortical anatomy, just points to remember essentially is that these will allow us approximation to some of these regions, such as the central sulcus can be projected about 1 centimeter posterior to the midpoint of the Nacian-Inian line, running obliquely downwards and forward. Right, this will essentially separate the precentral gyrus or the motor cortex anteriorly, and the postcentral gyrus or the sensory cortex posteriorly, with the Sylvian fissure originating near the pterion, which then marks the boundary between the temporal lobe and the frontal parietal lobes, and serves as the key corridor for a number of microsurgical approaches, right? So with these in mind, we have to eventually discuss not just the craniometric points, but their relevance to all of this through various localizing methods, right? So classic surface marking systems provide a reproducible method of translating scalp anatomy into the underlying cortical, ventricular, and vascular relationships and which allows us safe surgical planning, even in the absence of advanced image and guidance, right? The process begins with establishing a reliable cranial coordinate framework, and this is anchored by the Nasion-Inian line, which I would have mentioned earlier. Right, the line is drawn from the Nasion anteriorly to the Inian posteriorly and represents the true cranial midline and approximates the course of the superior sagittal sinus. So this serves as the principal longitudinal axis from which our other measurements are going to be derived. And the midpoint of this line is particularly important as it forms the reference for the projecting the central sulcus, right? To complement this line, a horizontal reference can be established using the Frankfurt horizontal plane as viewed in the image on the slide, right? It's defined by a line extending from the inferior orbital margin to the superior margin of the external auditory meatus. And this plane represents the anatomical horizontal orientation of the skull and ensures consistency in head positioning. Closely related to this is Reed's line, right? Or the orbitomeatal line, which runs from the infraorbital margin to the center of the external auditory meatus. In practical terms, these planes align our spatial understanding with radiological imaging and serve as the horizontal axis of the cranial coordinate system. Once these orthogonal axes are established, vertical orientation is achieved using the posterior auricular line drawn through the posterior margin of the external auditory meatus and acts as a vertical reference, which helps to define the anterior-posterior extent of cortical structures, particularly in relation to the temporal and parietal lobes. Together, the Nasion-Inian line, the Frankfurt or Reed's baseline, and the posterior auricular line form a three-dimensional coordinate system that allows precise spatial mapping of the brain. Within this framework, the Taylor-Houghton method is used to project key cortical sulci. Right, the central sulcus is defined by locating a point approximately 1 centimeter posterior to the midpoint of the Nasion-Inian line and drawing an oblique line downward and forward at an angle of roughly 70 degrees towards the preauricular region. This line represents the boundary between the primary motor cortex anteriorly and the primary sensory cortex posteriorly, making it one of the most critical functional landmarks in neurosurgery, right? The Sylvian fissure or lateral sulcus is then projected beginning at the pterion and extending posteriorly and slightly superiorly. This fissure separates the temporal lobe from the frontal and parietal lobes and forms the basis of the transsylvian surgical corridor. This is widely used for accessing the middle cerebral artery and anterior circulation aneurysms. Additional reference lines further refine localization. The condylar line drawn from the mandibular condyle towards the mastoid or occipital region helps to approximate the inferior boundary of the cranial vault and provides orientation for skull base and posterior fossa approaches. Meanwhile, relationships such as the Inian to Asterian trajectory approximate the course of the transverse sinus, and the Asterian to mastoid pathway reflects the course of the sigmoid sinus, both of which are critical in avoiding venous injury during posterior fossa surgery. Taken together, these classical methods allow the surgeon to construct a mental three-dimensional map of the brain using external landmarks. They guide us in burr hole placement, craniotomy design, avoidance of critical neurovascular structures, and while also all the while aiding in the localization of eloquent cortex. Although modern neuronavigation and functional imaging have greatly enhanced our ability in terms of accuracy, these traditional techniques remain indispensable, especially in resource-limited settings. They provide not only a practical backup in challenging situations, but also a foundational understanding of spatial neuroanatomy that underpins all of our neurosurgical practice. Moving forwards in terms of ventricular access, I'm going to mention a few, right? Kicking off with Hooker's point. This is one of the most important and reliable cranial entry points in neurosurgery and represents a more standardized frontal burr hole location that allows safe access to the frontal horn of the lateral ventricle while avoiding, cortical structures and major vascular structures as well. It's classically located along the mid-pupillary line and approximately 2 to 5 centimeters, 2.5 to 3 centimeters lateral to the midline and 10 to 11 centimeters posterior to the nascent. Alternatively, we can also have a 1 centimeter anterior to the coronal suture as another guide. The positioning places the entry point within the middle frontal gyrus anterior to the precentral gyrus, thereby avoiding the primary motor cortex and lateral to the superior sagittal sinus as well, minimizing the risk of venous injury. To identify Coker's point, the process begins with establishing the nascent inian midline, which defines the cranial midline or approximates the course of the SSS, the superior sagittal sinus. From this, we measure 2.5 to 3 centimeters lateral to the midline and 10 to 11 centimeters posterior to the nascent. The intersection defines Coker's point, but can alternatively identify the coronal suture, right? Alternatively, we can get to Coker's point as well by identifying the coronal suture, marking a point 1 centimeter anterior to it, and then moving 2.5 to 3 centimeters lateral to the midline. This is often more practical intraoperatively when sutures are palpable or visible. So we mentioned the most common way to arrive at Coker's point, which is the Nassian-based method, as well as but it's important to keep note of the coronal suture method, which I just described. However, that one is possible intraop. Another way to find it is using the mid-pupillary line method, which aligns the vertical, you align vertically with the mid-pupillary point and track posteriorly around 11 centimeters, in the direction posterior, essentially, right? Which is imperative and can provide a quick bedside estimation, especially when landmarks are not properly visible or when they're obscured. And here we have a couple other access points and methods. So beyond Coker's point, there's several classical alternatives and entry points into the ventricular system, namely Fraser's Point, Dandy's Point, and Keene's Point. These provide access to the different regions of the lateral ventricle and are selected based on surgical need, anatomy, and the requirement to avoid certain cortical structures. Starting with Fraser's Point, this is a posteriorly placed entry site used to access the occipital horn of the lateral ventricle. It's located approximately 6 centimeters above the inion and 3 centimeters lateral to the midline, placing it within the parieto-occipital region. From this point, the trajectory is directed anteriorly and slightly medially towards the occipital horn. And the main advantage of Fraser's Point is that it avoids, accessing or being in the region of the frontal lobe and the motor cortex, making it useful when anterior approaches are not suitable. However, because it lies close to the visual cortex, amongst the risks lies visual field deficits, particularly homonymous hemianopia, which limits its routine uses, right? Moving onwards to Dandy's Point, this is another posterior approach located in the posterior parietal region, approximately 3 centimeters lateral to the midline and just anterior to the lambdoid sutures. The trajectory here is directed inferiorly and slightly anteriorly to enter the body of the lateral ventricle. Historically speaking, this point was widely used for ventricular puncture and procedures such as pneumoencephalography. However, in modern practice, it's less commonly used, but remains an important from an alternative perspective. The principal limitation is the risk of injury to the parietal association cortex, which may result in higher cortical dysfunction. And finally, Keene's Point. Right, so Keene's Point is a lateral entry site that provides access to the atrium or trigone of the lateral ventricle. It is located approximately 2.5 to 3 centimeters superior and posterior to the external auditory meatus, placing it in the posterior temporal or inferior parietal region. The catheter in this case is directed medially and slightly anteriorly towards the ventricular trigone, and this approach is particularly useful when frontal access is not feasible and is sometimes used in neuroendoscopic procedures or selected ventricular drain placements. However, it does carry a risk of injury to the optic radiations and potentially can cause visual deficits and as well as to language area in the dominant hemisphere, right? So this concludes the presentation today on surface landmarks and scalp anatomy. Thank you, everyone.